I think when we look at the history of our worldviews, that this idea of the body and the mind, or the body and the spirit being separate things, really comes from a Greek worldview, a Greek dualistic worldview where these were separate things.
Yeah. Hello, welcome to Restore Healthcare Project. I'm Dr. Jennifer Kang, and I am here today with my favorite Dr. Lysa Owen from Derry, Northern Ireland. Welcome.
It's lovely to be back.
We have a great topic that we would love to cover today with you. I think it's fun because of your insights, but also because it's so relevant and includes a buzzword in healthcare today, which is whole person care. And you have, I think, a very unique and special perspective on that. So I'm excited to be able to kind of unpack this with you a bit today. I'd love to start with just let's construct a roadmap to how we got to this idea in healthcare and your perspective on it. Why is it that we need to talk about this? And I think there's a whole historical context for that. And I'd love for you to speak to that, starting with the biomedical model.
Yeah, so much to talk about in this one. So I graduated as a medical doctor from a 5-year medical degree, and I was taught myself very much from a biomedical perspective, and I was really taught from the sciences. We started off and we learnt our basic sciences. We learnt our anatomy, physiology, biochemistry, and so on. Then we learnt about what happens when things go wrong, pathology, pathophysiology, and then we learnt about managing diseases primarily. And during my medical education, there were some additional things that were added on to that dominant biomedical model that encouraged us to think about the psychobiosocial. But I think the hidden curriculum was very much that the disease model, that the science was what was really important in being a good doctor.
Yeah.
And I passed my exams and graduated.
And you survived the cadaver lab.
Yes. And when I began to practice, though, I did find that really that biomedical model kind of let me down. It just felt like it wasn't quite enough when I encountered patients. And it also wasn't quite enough in that it didn't necessarily give me maybe the degree of personal satisfaction in my interactions with patients as well. And I guess I began to develop my own consulting style and really began to discover that there was a lot more to it than just identifying the pathology and instituting a management plan. And I guess that has underpinned my approach and my interest in medical education, because there's a shortcoming, isn't there, if the structure and the framework and the priority, particularly within the hidden curriculum, is that this is all about knowing your science, recognizing the disease process, and considering the management options. But the medical curriculum is already busy. And if we just bolt on other bits on top of that, then it just becomes crammed and it becomes busy.
Overwhelming. Yeah.
And maybe also for the practitioner, the healthcare provider, who's busy trying to do their best for patients, for people under their care, that if we start asking them to now do this thing as well and that thing as well, that they can sometimes feel, I'm already so busy, how can I add on more? And so for me, there was a gap. There was a disconnect. There was a bit of cognitive dissonance about what was really bringing to me professional satisfaction and actually having satisfied patients at the end of the day that really made me begin to think deeply about this.
Well, and certainly just to kind of signpost at this point, you're not saying the biomedical foundations of modern healthcare are not valid. And certainly, we're now living in this beautiful breakthrough after millennia almost of humankind dealing with disease and health through many superstitious lenses, religious overlays, and honestly unhelpful things in terms of the understanding of disease. So we're actually living in this century of medical breakthrough that's really quite lovely, and in many ways, that's incredible that we get to live at this time in the world, and there's validity to that. Perhaps, though, we've seen over the last century, there's been a bit of shift because of what you're describing, that this biomedical model, although leading us into the breakthroughs of science and being able to really, truly understand at a molecular level disease and treatment and really get people whole at a physical level, we've realized we threw some things out. We left some things behind. And as you referred, trying to bolt them back on has been quite an endeavor. You would agree with that?
Oh, absolutely. We absolutely celebrate the fantastic scientific breakthroughs and those who went before us, who made those wonderful discoveries that have enhanced societal and individual well-being. Fantastic. But not enough on its own.
Yes.
Not enough on its own.
And I would say I relate to that too. Where I trained in medical school was a school that was in the US, very innovative in pioneering this biopsychosocial model of medical education. You referred to this. So you have experienced this in Europe as well. And it was really promoted as this innovation 20, 30 years ago of taking the biomedical model and expanding to include other aspects of a person's being, to make sure that we're also caring for their psyche and for their mind and for their social situation, because we realize these are important determinants for health. So that felt like a progression and an innovation, but maybe it's not quite there. What do you think?
Yeah. I suppose in your context and mine, we are encountering a differing patient population, aren't we?
Yeah.
And the time at which, about 100 years ago, when the Flexnerian model of medical education, Flexner and Osler and some of those pioneers, they were dealing with different populations, weren't they? They were often dealing with people who had a single disease within a single organ. We now have a population who are maybe living longer with multiple conditions and so on. And I guess one of the ways that I sometimes encourage students to think about this is that I sometimes ask them to compare to real life, a conversation. And I might say to them, have you ever had a problem, something that you've been upset or worried about, and you've spoken to a friend? Everyone can relate to that context. And actually, when we unpack that for ourselves, we say, well, what helped in that scenario? Do you want the friend who's going to give you solutions? Not necessarily. We're not necessarily looking for a solution to the problem, but actually what uplifts us is the human connection of the friend who hears, who acknowledges, and who's prepared to sit alongside us for a time. And sometimes it's really annoying when that friend says, well, you just need to do da, 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 da. Yeah. And where I think in medicine, for all sorts of reasons, we often have a culture of fixing things. We often have a culture of fixing things. And so when we think about that context of people living longer with multiple conditions that we can't always fix, but there's something about the human connection, about valuing the human experience, the dignity of the person with us, and meeting them with compassion that doesn't require an approach that says, make the diagnosis and institute a management plan. In other words, fix it. So I think that is a way of understanding it, that there is something incredibly restorative and healing in human connection. And it's difficult. That's a difficult thing for us to measure. And some science has looked at it, and we know how important it is. And we know the awful effects on well-being when human connection is lost and it breaks down through attachment, through personal traumas and so on. We know that that is so bad for health and well-being, and it results in illness, lack of wellness. And so we really do need to acknowledge the importance of human connection, the impact when that has broken down for patients, and to actually value ourselves as therapeutic, through the human connection of coming alongside someone. And we need to model that, I think, more so than teach it, but we do certainly need to understand and practice it.
And that is something that's very hard to give language to and to teach in a discrete, protocolized way. And you certainly have experience. This is part of your specialty in medical education, is teaching communication skills to medical students. Our patients give us feedback that they're dissatisfied with the current healthcare system. Isn't that something we frequently hear out, that doctor's bedside manner was terrible, that nurse just rushed, she didn't listen to me at all, she just jumped ahead to get the tasks done, check, check, check. What are they actually communicating? They're trying to say this connection is missing, and we inherently, instinctively know that connection is necessary. Like, that's what we're looking for. That's what we want. Yes, we want this is what you have. We want the diagnosis. We want somebody to explain our experience, but we also want somebody to sit with us in our experience too. That's difficult in our healthcare culture right now, isn't it?
It's very difficult. And as an educator, with my educator hat on, there's a truism, isn't there, that assessment drives learning. And one of the things that I've been working on recently in my academic context is changing what we assess, changing how we assess. And rather than rewarding students who can check a lot of boxes in their approach with patients, I worked with patients and their representatives to say, what matters to you?
Wow.
What are you looking for in your clinician, in your doctor, in your physician? And I took what they told me and I incorporated it with what our clinical experts and medical educators said, and created a new way of scoring our medical student in their clinical interactions that included supportiveness, responsiveness to patient cues, and making the patient's main thing the clinician's main thing. Alongside that, one of the domains that we're including is technical expertise. We're not talking too much about that today because it's a given, isn't it? That we expect technical excellence. You do need to do the right thing in the right way, but how you do it, it's about process, isn't it? It's about how you approach it, rather than, it's not just about what you do, it's about how you do it.
You're elevating that then to be equivalent components of the recipe. Not only do you perceive and extract your data with technical excellence and come up with correct diagnoses and treatment plans, but you're also then connecting and communicating with, you're equating those as equally important in that therapy.
Yes. And we know ourselves. I mean, you must have experience in your own clinical practice of the consultation that was technically impeccable.
Yes.
But the patient was still dissatisfied. But similarly, sometimes you might have had a bad day, and technically, it may not have been the ideal consultation. You may not have reached the correct diagnosis in a timely manner, but yet the patient is very satisfied with the consultation because they felt seen and heard and valued as a person. So that kind of brings us back around to this idea of whole person care. And I think it's a buzzword right now in our healthcare culture. And I think it's being used in different ways. So I'd love for us to define a little bit. I think
a current understanding might be whole person care is incorporating all different modalities to meet a patient's needs. And so that could be biomedical care, behavioral health, social services. I think that's not what you mean when you refer to whole person care. Could you walk us through what is the definition as you see it?
For me, whole person care is considering the patient, the person before me, as a person who's made up of body, mind, and spirit, not as separate entities, but as intricately interwoven and intertwined elements to their being and their self.
Hey, Healthcare Tribe, I hope that you have been impacted by what I've brought through this podcast. I also want you to know about opportunities to give back through my nonprofit, Selah Health International. We work to support projects for women and children of vulnerable populations around the world. You can learn more and donate on our website, selahhealthinternational.org.
I think when we look at the history of our worldviews, that this idea of the body and the mind, or the body and the spirit being separate things, really comes from a Greek worldview, a Greek dualistic worldview, where these were separate things.
Yeah.
Where the body and the deeper part of self, whatever language we use to describe that. And I don't think that is a worldview that I share.
Yeah.
I think I have a biblical worldview, which says that we are whole people. And there's emerging evidence, all over the place about the profound impact that our sense of self, our spiritual well-being, our emotional well-being, and our mental health have profound implications for our physical health. And if we want to provide whole person care, for me, it is about addressing spiritual need, spiritual distress, alongside mental health, emotional well-being, and physical health and well-being.
And so you're really saying that it's indivisible, the body, soul, and spirit, and the interaction and interplay exists across the spectrum of health. And so you couldn't only focus on just the physical body in healthcare and expect the person to be whole.
Yeah, isn't there some fascinating emerging evidence about epigenetics, isn't there? Where people who have experienced deep emotional trauma, we now have a putative mechanism that helps us understand how that impacts our physiological responses to stress, not just only in the person who's experienced that trauma, but actually in future generations.
Yeah.
Such an exciting and emerging area of medicine, which really reinforces scientifically exactly what we're talking about, which is our emotional and spiritual self is key to our well-being.
Like we see that in the research on adverse childhood experience, influencing later disease experiences in adulthood. There's multiple chronic diseases that have been associated with an emotional and environmental and social, and I would say spiritual experience as a child. We see that in refugee camps, refugee families experiencing trauma of war and displacement generations down. I think it's fascinating to look at that data showing changes on the DNA, physical changes as a result of what is not, it's a physical experience, but it's essentially an emotional, psychiatric, and spiritual trauma. So there's interplay, and to disregard that would be to our detriment. This is whole person care.
Absolutely. Absolutely.
So how do we do it? Because I think what a clinician who is overwhelmed with a large volume of care might be feeling when we say this is, oh, great, another thing that I am responsible for. How am I going to also do this whole person? Like, oh, now I have to really think about the interplay between maybe I was with emotional care, but also spiritual need and care. How do we frame that?
I think we can frame spiritual care using exactly the same models and structures that we have for any other kind of care.
Mm.
When I interact with a patient, I tend to have 3 basic questions in mind.
Mm.
And the 3 basic questions I have in mind might be, what can this person do to help themselves?
Yeah.
What can I do for them with my facilities and my skill set and my knowledge? And is there something that I think would help them which someone else can offer?
Yeah.
A specialist in that area, whether that's an oncologist or an orthopedic surgeon or any other specialist we could name. Patients do need to have responsibility and ownership and autonomy. And so it's really important for them to understand ways that they can help themselves. I can offer what I can offer, or I can offer them referral. I think it's similar with spiritual care, that actually the burden of the provider thinking it's yet another thing that I have to deal with. Well, it's not. It's about finding out in simple terms where the person is at and then signposting them. Well, what do they already have in their personal networks? What resources can they already tap into, and how can they help themselves deal with spiritual distress or unmet spiritual need? What can I offer them? And that'll be very variable, that I might have something different to offer to a novice or an expert in that area. And all of us are somewhere on the spectrum of all aspects of our medical knowledge between a novice and an expert. So I just need to have some insight. Well, where am I? Am I an expert? Am I a novice? Am I a generalist? Am I a specialist? Where am I? And we tend to know that for other areas of our medical practice, don't we? And if I identify that there is an unmet need, then I can refer to someone with more expertise than I currently have, irrespective of my comfort within that specialty area. So it's just a part of the normal medical history taking, isn't it?
Yeah.
And it sits just right alongside everything else, which is having a framework and being willing to ask some simple questions to find out what the individual's perspective is on where they're at in that element of their care. And then we have access to the patient or the person's existing networks and support,
Yes.
what we might have to offer, or how we can signpost them to someone who can provide expertise.
So, I mean, you're really saying this doesn't actually expand the weight on any individual clinician, because it's still within the context of multidisciplinary care models that we already have. Like, it doesn't throw that away. That's so critical and so important. It's still a team approach. And there is a piece that I can do and I can carry, but it's just a piece. We're whole teams as well. We don't have to be individual heroes to save the day for the whole person. I think that's really critical. And maybe we could take this from the abstract into the practical. And maybe you could give us an example of a patient encounter where that is kind of demonstrated. I think that would be really helpful to help us understand what you mean, how you approach it, and how that looks.
I have a memorable encounter, and actually I'm very grateful to that patient, because that patient changed how I thought and how I approached things too. So this is not a unidirectional interaction.
Yeah.
This is something where I gained through the interaction. I had a patient. She was a woman under my care in an inpatient context, and this was a woman who had acute on chronic pain. She had a new injury which was causing her acute pain, but this was on a background of troublesome, persistent chronic pain in multiple sites in her body. And when I was on my way to my first consultation with this woman, I'd picked up her notes and I'd scanned through them, and I'd looked at her drug chart, and I could see a vast list of drugs, multiple different groups of analgesia, multiple painkillers, long-acting opiate, short-acting opiate, drugs for neuropathic pain, antidepressants, a huge, huge polypharmacy collection. So good science says polypharmacy is not so good.
Right.
Deprescribing would be really appropriate here. That's the scientific medical model, which is good. And we have good learning and evidence and teaching and so on for that. So my medical aim was, I wonder if it would be possible to help this woman to rationalise this regime, but also aware that she had pain. And as I walked down the corridor towards this woman's room to meet her and to consult with her, I just had one of those pauses where I just had a breath in and a breath out. And my thought or prayer, if you like, was, I would like to make a difference in this woman's life.
That was your connection.
That was my sense. How long did that take? 2 seconds. It didn't occupy any part of my day, really. And when I began to consult with this woman, as I gathered information, as I found out about her history, I found out all about what had been going on, what had led up to this point. At one point in the conversation, she just really casually said something about her ex-husband. And in that moment, almost before I'd really fully processed it, the question was out of my mouth, and I found myself saying to her, "Can I just ask, was that an abusive relationship at all?" And I'm not really sure why I asked it, but I asked it. And she just went quiet and she paused and she looked at me directly and she nodded and she very gently said, yes, it was. And I held the silence for just a second or two. And I thought, I'm not going to rush her on. I don't have a platitude that can fix this.
Right.
And so I just want to acknowledge this and sit alongside her. Just like the conversation we had earlier. When you've got a friend and they're distressed or upset, they just want you to be there for them. They don't necessarily want to fix. So I just thought, I'm just going to wait. I'm just going to be here for her and find where she wants to go next with this. So she paused. She thought. She was processing. And then after what seemed like forever, it was probably only a few seconds, I just held the silence. And then she looked up at me again and nodded and said, yes, it was. And she was ready to move on. And we didn't talk about that trauma any further. But when we got to the end, where we were then planning her management and negotiating a shared plan, I was able to say to her, are these drugs really doing you any good? Are these really helping your pain? And she said, no, they're really not. And I said to her, do you trust me enough that we could reduce these medications? Do you trust me that I will not let you have pain which is intolerable to you? And she looked at me directly and said, yes, I trust you. But that trust had not been built without that difficult moment of acknowledging her pain, her emotional pain and her trauma, recognizing it and in a way validating it as part of her whole person situation. And over the course of her stay, we gradually, and without any worsening of her pain, we just gradually and systematically reduced drug after drug after drug. And by the time she was ready to leave, she was either off or had a clear plan with dates and times of when she was going to reduce all these things. That woman looked like a new person.
Wow.
It took a little bit of my time to make that connection, but my sense of professional and human satisfaction, I hadn't undone her trauma. I hadn't solved that, but I'd heard and seen and recognized it and actually inferred, because what the understanding was between me and this lovely woman was that maybe some of your pain is not being helped by drugs, because maybe the source of that pain is connected to your emotion. And so the emotional connection allowed us something like hope
Mm.
and healing. And I use healing
Mm.
in its broadest sense there, because whole person care has got a goal and a direction
Mhm.
of healing. And can we heal the body without healing the emotion?
Mm.
I'm not sure we can.
Mm.
That actually, when it's both and, rather than an either or dualism, not only does it do something beautiful
Mm.
for our patients, but actually it does something for us as clinicians, which is it touches us at a human level, gives us a sense of professional and human satisfaction. And I think that helps us reduce our risk of burnout. I think it makes us resilient practitioners. So it's a win-win. It's good for the patients and it's good for us.
I love that. It seems so simple. You're not laying out that we're going to need to have this responsibility to step into doing cognitive behavioral therapy with our patients when we identify an emotional need. There is a beautiful place for that. Or that we'll need to step into a place of deep spiritual connection and prayer necessarily. But the seemingly simple connection, acknowledgement, and this bidirectional hope exchange is in itself enough to start this healing process, to reconnect the parts of a patient. I think that's what you're saying, that there's this great need for patients to move down this path of wholeness. They need to have somebody help them put the pieces together and give permission for it.
Yeah, that's a really good way to describe it, isn't it? To allow people to be seen, to be heard, and to give them permission if they want to unpack things some more. And I won't necessarily have the skills to do that. But just like we said, I might not have the skills to deal with that. But if it's transparent and if it's out in the open, then I can signpost them to, here's things you can do to help yourself. Here's what I might be able to do for you. Or would you like me to refer you to a specialist in this area?
But oftentimes people will identify this was a moment in time when something changed for me. I think you're describing that in this particular patient's life. Something changed for me, and you got to be there in that moment to show a different road. And as she began to go down that, it's a gradual process. It's not perhaps the dramatic magic wand. And yet it is a discrete moment in time that we have this great privilege of participating in. This whole person idea can be that for many, many people.
So such a good word. Yeah. Such a privilege, actually. And I guess when we're thinking about clinician burnout and things that we can do to enhance resilience, I think this is a part of that solution, and I think it's a part of that to build resilient practitioners. The resilient practitioner is the one who goes home at the end of the day with a sense of connection. And a sense of having fulfilled something meaningful about their purpose and an expression of perhaps their calling and their vocation.
You expressed this breath prayer of, I just want to make a difference. And I think that's in all of us as a driving force for why we're here in healthcare. This bidirectional hope, that experience of, I think I could make a difference. I think I may have. What if I made a difference? that feeds you. You're describing how that almost in a way ministered to you, not drained you.
No, not in the slightest.
Is this what we're missing in patient interactions that's leading to this burnout?
Yeah, I think so. I think our culture is one of individualism. And I think when we view ourselves as individual clinicians and individuals responsible for someone else's, a patient's health, well-being and care, that's a heavy burden to carry alone, isn't it? But actually this concept of we're a team, we are a multidisciplinary, multi-professional team, and we have access to others. I think sometimes we miss the opportunity to consider the patient themselves as part of our multidisciplinary team, and that we might be energized, invigorated by their perspective. I certainly wasn't expecting a woman on a huge cocktail of drugs for persistent and difficult pain to have had a positive impact and a restorative impact on me. But that's what happened on that occasion. Yeah.
So whole person care, this may be a beautiful, empowering thing for our patients and for us as clinicians as well. This has been really fun to unpack this with you. There's a lot more, but thank you for sharing your insights on this, your experience. I think it's very impactful and meaningful. Thanks for being with us. I'm Dr. Jennifer Kang, and this has been the Restore Healthcare Project. Hey, Healthcare Tribe, I hope that you've been impacted by what I've been able to bring through this podcast. I also want you to know about some opportunities to give back through my nonprofit, Selah Health International. We work to support projects for women and children of vulnerable populations around the world. You can learn more and donate on our website, selahhealthinternational.org.